Okay, welcome back to the Procrastinator's Guide to the LLSA 2015 edition, and I'm recording this on January 11th, 2017, so 2 years in past when I was supposed to, but I still got a year to finish this set. And this article is called Questioning the Use of Epinephrine to Treat Cardiac Arrest by Clifton W. Callaway, MD, PhD, from JAMA, March 21st, 2012. And this is an editorial on the other article we just did, the one by Hagihara, called Prehospital Epinephrine Use and Survival Among Patients with Out-of-Hospital Cardiac Arrest. And in that article, they looked at the use of epinephrine in cardiac arrest patients, and they found that it actually could create worse neurologic outcomes and even death, more death, in patients with cardiac arrest, which is really counterintuitive to what we've been doing all this time. And the first reference in this article is by Prasad, Sifu, and Ioannidis. It's called Reversals of Established Medical Practices, Evidence to Abandon Ship, which is really what this is about. Is it time to stop using epinephrine in cardiac arrest? Especially given that it might be hurting people. Now, the thought has been that during cardiac arrest, the patient obviously has low blood pressure, and then that leads to decreased coronary perfusion, and presumably, they'd have less likely to have a positive cardiac outcome. So epinephrine, through its alpha adrenergic effects, is going to increase blood pressure, and that will in turn increase coronary blood flow. And that makes physiologic sense that would work, and so that's what we've been doing. Now, the original studies that justified this came from a couple of them in the 1960s in dog studies. And apparently, as the paper says, there has been no weight adjustment or interspecies comparison for adult patients ever since then, which is a little bit mind-boggling for such a widely accepted practice. So what is going on here? Why are we actually coming up with problems? So epinephrine obviously has both alpha adrenergic and beta adrenergic effects, and we know that the alpha adrenergic may be good for coronary blood flow, but this might come at the expense of cerebral blood flow. And there's a sentence in here that says the data suggests that epinephrine provides short-term gain for the heart by incurring a metabolic debt from the body and the brain. And that's not all that's going on. These beta adrenergic effects may be causing some problems. So they can obviously cause dysrhythmias and even tachycardias, which are going to increase cardiac oxygen demand. And they can also activate platelets, and they can increase coagulation, thereby creating a thrombotic state, which could then lead to myocardial ischemia, which of course then leads to arrest. So epinephrine may not be doing exactly what we want it to be doing. So what does all this mean? There's really two main points that I'm getting out of this article. The first one is the concept of surrogate versus patient-oriented outcomes. Now, for us, the surrogate outcome would be a return of circulation. So with epinephrine, you're able to get circulation back. But the patient usually will have either poor neurologic outcome or they'll die before they leave the hospital. And so while the patient doesn't necessarily care that they survive the arrest temporarily, initially, they want to live. They want to leave the hospital. So that's a patient-oriented outcome. So this is a very important distinction we need to make. And the other thing is that now we have enough evidence to do a proper clinical trial on this, whereas the use of epinephrine had been so ingrained into our practice, it probably would have been unethical to try to do a randomized controlled trial where some patients did not get epinephrine, they got a placebo instead. But this now is contradictory to our common practice, so now we can do that study. And so that's this short little video on the editorial to the previous article in the Procrastinator's Guide to the LLSA. See you next time. Thanks for watching.